is Philipp from Gottberg. I'm a neuroradiologist at the Stuttgart City Hospital in the town of Stuttgart in Germany, and I'm going to talk to you today about pearls and pitfalls in CT and MRI perfusion imaging of stroke. First of all, why perfusion imaging in stroke? So we all know that plain CT scans can show infarction, acute infarction of brain tissue through the loss of density in the gray matter. Early CT signs can be seen in the earliest 2 to 3 hours after the onset and after the ischemic infarction of brain tissue. However, this imaging does not contain any information about tissue that may still profit from therapy, that is so-called penumbra or tissue at risk, which then would not be seen within cytotoxic edema, and also CTA, which may show a very precise location of a vessel occlusion, is also not having any information on that. We have better chances in finding out whether there's tissue at risk in MRI if we form a FLAIR DWI mismatch, if we just overlay these two images and see whether there's any mismatch in the coverage in both signal intensities. However, DWI may be delayed up to 30 minutes behind the ischemic evolution. Also, it may be quite imprecise to form the mismatch out of these two, and also MRI is also not well accessible, not throughout all times of the day, and there's also contraindications to that. So both modalities, both methods actually don't have the advantages of perfusion imaging, and actually don't have this high level of identification for penumbra or tissue at risk as the perfusion imaging might have. And having this identification of this tissue is actually crucial for the decision on treatment of acute ischemic stroke. Two studies that were published in 2018 had a huge impact on the treatment of ischemic stroke, since they both furthered the time window in which patients can be suspected to profit from therapy. Before that, the barrier was at around 4.5 hours due to the ECAS-3 data, the time window in which patients with acute ischemic stroke would be believed to only profit from treatment, whether it be mechanical thrombectomy or intravenous installation of recombinant tissue plasminogen activator lysis. However, these two studies identified patients through careful selection that would still profit up to 24 hours after stroke onset from mechanical thrombectomy, and this was done through perfusion imaging mainly. Ever since the recommendation for carrying out perfusion imaging for patients presenting after 6 hours of onset at the hospital has been entered national and international guidelines. So let's have a look at what happens at an infarction ischemic event in the brain. So we would always have an infarction core at a certain point in time. So this is tissue that actually does not profit from therapy anymore at whatever time it is set up. So this infarction core is the lost tissue. It will be surrounded by tissue that is, let's say, too well perfused to die, but not enough to survive. This is the so-called penumbra, or tissue at risk. And this will have a zone around it with oligemia, with low blood flow, which is but still not crucial for this territory, which is still not ischemic. Or it may even be surrounded by luxury perfusion, meaning that there's a higher perfusion than normal due to vasodilatative factors that are emitted by the penumbra and infarction core tissue. This is not a static system, so if we have to look at this schematic view of the brain, let's say after 30 minutes, we have a huge territory in light blue, which is penumbra tissue. It has temporarily lost its function. It may regain its function if it is saved in the right time. We don't have an infarction core yet, and we have a dark blue surrounding area of hyperperfusion that somehow keeps, through collaterals and through diffusion, keeps this light blue tissue still living, that is cut off from its main supplying vessel. After 2 hours, however, we see an infarction core growing, and it's eating through time. It's eating into this tissue at risk, into this penumbra, and will eventually fill out the whole penumbra area if just enough time passes by. This is highly dependent on the vascular anatomy of the patient, and it is highly individual in every human. So if we just have a look at this, let's say we have a row of patients that all suffer from acute ischemic stroke at the same time, at the same moment, then some will suffer from unreversible stroke, from unreversible ischemia earlier than others, depending on their vessel anatomy. And this is what diffuse 3 and Dawn showed. There will be some after the time window of 4.5 hours, the time window after which the venous lysis will not do any good anymore, probably. These patients will still be profiting from mechanical thrombectomy if they're just selected correctly. And for doing so, perfusion imaging is the key. Let's just have a look at the terminology in perfusion imaging. So the first two, the cerebral blood flow and the cerebral blood volume, are the main parameters for identifying ischemic core and tissue at risk. They are both measured in milliliter per 100 gram per minute for the flow and milliliter per 100 gram for the volume. And then we have the timely parameters, which are the mean transit time, time to peak, time to drain. Mean transit time meaning the blood flow, mean blood flow through the investigated origin. In this example, it's brain tissue. Normal values would be 4 to 5 seconds in brain tissue. The time to peak is the time it takes from the start of the scan until the maximum concentration has been reached, and the time to drain is the opposite, from the maximum peak until great normalization of the curve. If we transfer this to our exemplaric ischemic region, then we would have a very high CVF, CBV, and mean transit time in the hyperemia and in the surrounding tissue to the penumbra. And the penumbra, it would be below normal, below physiological values, so still not as small as in the infarction core, where it just would be underneath the value that is like it's in the death zone for neurons. So far, so good. If we go into the clinical application of perfusion, then one question that arises quickly is, which one's better, CT perfusion versus MRI perfusion? There's no definite answer to that. Actually, both have their pros and cons. The only thing one can say is that in actually every major stroke center throughout the United States, Europe, and every other part of the world, actually CT imaging in acute ischemic stroke is now the main part, while MRI is actually not in the dominant role anymore, and is more for the follow-up imaging. And it's mainly due to the first 3 or to 4 pros of CT scanning. It's the good access. In every smaller hospital there's still a CT scanner. It's quick and has nearly no contraindications. Especially for ischemic stroke, there's no contraindications, and it's very robust to artifacts. And already these 4 pros are actually the 4 biggest contras of the MRI, especially the accessibility and the contraindications. Just think of metal implants or pacemakers and patients that are maybe sometimes in reduced cognitive state and just can't lay still. In these patients, MRI becomes difficult. So a typical protocol just for CT scanning could be a basic CT scan to rule out hemorrhage, then a CT angiography to locate the vessel occlusion, and then CT perfusion to investigate whether there's still tissue that would profit from therapy, so the tissue at risk through the mismatch calculation. And it may look like this in your clinical practice with the CVF-CBV mismatch in this part, which used to be the main tool of mismatch calculation in the elder studies and newer studies, especially the Dawn and the diffuse 3 study. The CBF decrease under 30% of the contralateral healthy hemisphere would be considered unrescuable infarction core. This is actually a very good principle. I will show you later why I think this actually still should not be the only way to calculate the mismatch, and why this can be distorted in automated perfusion reading. Also, Tmax above 6 seconds can be considered as tissue at risk. This is actually how the diffuse 3 worked with an infarction core with a Tmax time to peak over 10 seconds. So let's come to the pearls and pitfalls in perfusion imaging. We have very good CT scanners. Meanwhile, there's very precise possibilities to calculate the parameters of perfusion especially, and actually there have been a lot of advances technically and also in the software side in the last years, and it's looking good for CT and MRI imaging. However, in practice there's this patient that will just not be able to lay still in the gantry and will just move the head throughout nearly the whole scan and create data that will actually not look like as if it's readable. So I just put this data from this very patient into the software, and this is actually what comes out. So this is actually not readable data. This is like trash in, trash out principle. Data input that is not actually good data will not create a very good result. So this looks like a lost examination. However, if we have a look at the first slide, we will see that there's a heavy distortion already in the beginning of the scan. This is where the patient moved the head. And afterwards, actually, these curves do make pretty much sense. Which is for this yellow and white curve, I hope you can see it well on the screens, which are the two hemisphere perfusion curves, and the blue curve, which is the venous outflow curve. The red curve, you can see, has this elevation in the beginning and then stays flat, and this doesn't make sense because the red curve is the arterial curve. So how can we have venous outflow of contrast agent if there's no arterial inflow? So this means that there's an error in the automated process of the reading of this perfusion data, and if we get into this, we can just, when manually reading this data, we can just, in every software, we can just cut out this part, and actually if we do that, we can get quite well imaging, and this whole examination is not lost, but actually can be done, can be read very well. Sorry for these black boxes, this is for anonymization, but you can see in this very patient, after correcting the images, and this is one of the polls, if you just go manually into the evaluation of your data, you can still rescue this quite heavily affected examination, which is heavily affected by movement artifacts. Let's go to this patient who suffered from acute onset of ataxia and had a suspected stroke in the posterior circulation. This patient actually was already prone for MRI due to the fact that it was very likely to be a stroke in the posterior circulation. The fossa posterior is, in plain CT imaging, is a weak part of this method due to the high density of the os petrous bone, which is just absorbing too much radiation. However, if you look at the principle of CT perfusion, which consists of administering a higher density agent, contrast agent, then actually we shouldn't be worried too much about the posterior fossa. And in this patient, you can see that this actually worked out pretty well. And this is a patient with a superior cerebral artery infarction. And you can see well the ischemic perfusion part here in the left side of the cerebellum. And so actually for larger vessel occlusion, and this starts with the perforating arteries from the basilar artery, there's actually no need to worry about the posterior fossa in CT perfusion if the field of view is set correctly. This is a patient that was actually suffering from symptoms of stroke, but CT imaging, CT perfusion imaging in the automatic evaluation didn't give any good data, so you can already see here that these curves don't make any sense. If we just have a look at the automated reading of this data, we can see that there's not much value in that. We are not able to identify any good values for CBF, CBV in here. And still here again, if we have a look at these curves in the beginning, we see that this is actually something that doesn't make sense. So after the beginning of the scan, our hemispheric perfusion drops below 0, which is just physically and physiology not possible. So then this is definitely some kind of error in the identification of vessel. And this is a so-called arterial input function failure. The arterial input function is actually the baseline identification of vessels, which then is, well, it's the concentration of contrast medium in an artery, which is measured over time in a ROI, which is essential for the software to be able to create the perfusion values by seeing where the onset, the peak, and the decrease parts of the examinations are. This arterial input function is done by identifying a vessel which definitely is an artery and a vessel which is definitely a vein, a venous segment. If you do this manually in this examination, and I strongly advise to have, for example, the anterior cerebral artery, because you can include two arteries that probably are from two different supplying vessels. So in this case, it's both internal endocardial arteries, and like this, you are a little bit more resistant to artifacts due to maybe uneven supply of the brain hemispheres due to arterial stenosis. And for the venous segment, I advise to have a huge venous sinus, for example, the transverse sinus. If we apply this to this very examination, you can see that this actually smoothens the lines, corrects the lines, and we will be able to have better information in the image. And this is actually now a readable CT perfusion image. Here I just lined up both next to each other to see the difference. This is a patient that suffered from heavy cardiac insufficiency, and this is actually a bad pitfall, because what you can see here is that the time it takes for the contrast agent to reach the brain after the start of the scan is already nearly beyond the time of the whole scan. So we have a scan time of 50 seconds, which is already quite long, and even after 40 seconds, the arterial peak has nearly been reached. It's hardly been reached. We just see the outflow here. However, in CT perfusion, the crucial parts of the examination is the beginning of the arterial increase and the peak, reachment of the peak. And then if you still get some data on the venous outflow, actually from this part only of the whole examination, you can already create readable images. And in this case, if we just adapt our images to this cardiac output insufficiency, I will show you how this image performed in reading. So this is not very well, actually. We don't see any valuable information on that. But if we just do correct our images by reducing the noise which is created if there's too much a non-contrast scan of the perfusion, meaning there's a too long time in which nothing happens, then a lot of contrast noise will be built up, which can be eliminated by increasing the threshold. Threshold means that a vessel segment is identified as a vessel segment, and others are skipped, so it needs to be a certain level of concentration until a part of the brain is considered a vessel. And if there's too much noise in the image, there will be too much false parts of the tissue considered as vessel, which will then create this distortion in the image. So if we set up the threshold, the level after which the concentration in the part of the brain will be considered a vessel, then we can smoothen these curves, and we can eventually have here, as you can see here, we can eventually have readable perfusion image as for this cardiac output insufficiency. This is a patient that was actually suffering from occlusion of the left internal carotid artery, and he suffered from an hemodynamic stroke. You can see here that the perfusion image actually shows you the hemodynamic complication in this patient with ischemia in the posterior and anterior borderline of the middle cerebral artery and the anterior cerebral artery. So perfusion imaging here can already give you an information about the vessel status, and you can see the ischemic parts here. This is a patient who suffered from a seizure, and following the seizure, visual impairment. Actually, what we can see here is hyperperfusion due to the seizure, and these just graphically highlighted regions here will show you that this patient actually has a hyperperfusion, also seen here with a very high time to peak and very high time to drain. So this is the opposite of a stroke. This is a stroke mimic clinically, but which can be identified as a seizure on CT perfusion with just the ordinary values, which are just exceeding the normal values. So this is the opposite of stroke in this clinical stroke mimic. Also, this patient who suffered from right-sided hemiparesis following a seizure. Already in these curves, you can see that there's something wrong. The white curve representing the left hemisphere is much higher actually than the other side. So this is the opposite of stroke. And we have a look at the perfusion maps. We can see that in this patient, there's a hyperperfusion of the basal ganglia area and also the cortex in the left hemisphere, which represents seizure and the hyperperfusion following the seizure. Let's look into some further application. This is a patient that is suffering from a chronic occlusion of the left internal carotid artery, and this is the so-called acetazolamide challenge, the Diamox challenge. This is a vasodilatator given and CT perfusion before and after administration of this vasodilatation to find out whether there's actually still reserve capacity of the vessels. So if we have a maximum dilatation of the vessels already before giving the vasodilatative agent, then we won't see any difference in the perfusion maps, and then this patient would actually profit from a transcranial, from an extracranial, intercranial bypass operation. And we can see in this patient that he still has some reserve capacity, and before and afterwards we can see a quite increase in the perfusion maps, and this patient then actually still has reserve capacity and doesn't need to have a bypass surgery yet. Thank you very much for your attention. These are my references, and now it's open for discussion.